Good morning. Let's get started. My name is Kyungman Kim, and on behalf of the Department of Biostatistics and Medical Informatics and the School of Medicine and Public Health of the University of Wisconsin in Madison, it is a great pleasure for me to open this conference and welcoming you to all to honor our colleague and mentor, David L. DeMets, Max Halperin Professor of Biostatistics and Chair Emeritus of the Department of Biostatistics on his 30th years of tenure at the university, and to celebrate his contributions toward biostatistics and clinical medicine. In opening the conference, I would like to share a quote that I found a few years ago that is shown on the screen, given by Dr. Robert Gordon, who said, "With the advent of sophisticated biostatistical methods, clinical trials have acquired scientific respectability during the past 2 decades." I think this should become even more clear in the talks that we're going to hear throughout the day today. And in many ways, I think Dave, throughout his career at the National Heart, Lung, and Blood Institute and at the University of Wisconsin since 1982, kind of epitomizes a statistician's role in advancing clinical medicine. And this is just a slide that happened like 2 decades later after Dr. Gordon's comments about the role of biostatistics and clinical medicine. Dave gave Dr. Gordon's namesake lecture about the managing and monitoring multi-center clinical trial at the National Institutes of Health. And now, a decade later, we are gathered here today to celebrate Dave's contributions and to honor his leadership on many fronts and his mentoring to a number of us faculty members and postdocs and students. In opening the conference, Dean Bob Golden will give introductory remarks. As an introduction to Dr. Gordon, he received his medical degree from Boston University in 1979, and he's a professor of psychiatry here at the university. He came to the University of Wisconsin-Madison as Dean of the School of Medicine and Public Health and Vice Chancellor for Medical Affairs in 2006. Before coming here, he was Vice Dean for School of Medicine at the University of North Carolina in Chapel Hill. At the time of his coming to Madison, a kind of inside joke in the Department of Biostatistics was that we had to trade 2 of our faculty members, namely Michael Kosar, who is the chair of biostatistics at UNC Chapel Hill, and Jason Fine, to bring Dean Golden to Madison. Before I pass the podium to Dr. Gordon, I would like to take the opportunity to give credit where credit is due in terms of sort of putting the bugs for this conference in my ears, which will be illustrated in the slide next one. So this, as you can see, at the University of Wisconsin, Thursday is designated with letter R, and July 16th of 2009. It was a note I took at the first meeting I had with Dean Golden as an interim chair when Dave stepped down. And at this meeting, Bob suggested that perhaps we should organize a conference. Unfortunately, you see the date, June 1st of 2010 and June 2nd of 2010. Unfortunately, that year was the 50th anniversary of the statistics department, and Dave didn't want to have any sort of a overlap with that event. So we waited, but I'm really glad that we decided to postpone that event this year. By the end of this year, June, it'll be complete 30 years of Dave's service at the University of Wisconsin. And so what better occasion to celebrate his contribution. And so with that, I would like to pass the podium to Dr. Gordon. So, just leave that on.
Thank you. I've got to say, looking at that wonderful slide, I think you missed your calling as a physician in terms of your handwriting and penmanship. I really want to thank all of you for coming together to celebrate a remarkable career of a truly remarkable person. I appreciate that many of our distinguished guests have come here from all over the major medical centers of our country and beyond, including, of course, Raleigh-Durham, North Carolina, a place near and dear to me, Philadelphia, even Middleton, Wisconsin. So for all of you who have traveled here, thank you so much. I do want to say that many of us, including myself, will inevitably get quite serious, quite emotional, as we reflect on a remarkable person who has meant so much to all of us, meant so much to advancing the health of our country. But I want to offer a suggestion that even the most serious of family gatherings, such as Thanksgiving, usually includes a roast. So I hope we are able to mix it up a little bit. If you allow me, please, a little bit of perhaps a metaphor. I have come to believe, I've had to convince myself this, that being an administrator, as boring as it might seem to my wife, being an administrator in a way is like being an artist. And if you can accept that metaphor for a moment, Dave has gone beyond being a great artist. He has been a grand master. Let me explain what I mean by that. He was invited to come here in the early 1980s to basically create a vision and to paint it on a completely blank canvas. And he created a remarkable center, really cutting edge. And that wasn't big enough. He decided to go beyond and to expand to an even greater canvas, creating a world-class department of biostatistics and medical informatics. The spectacular glory of his art is just amazing. It's really earned national renown, and we are so proud of the works of art that have adorned the school and indeed have adorned the country. But even beyond Dave's own work as a grand master, he has created a remarkable artist colony. And so many people, including people in this room, have been able to benefit from his mentoring, his nurturing, his grand vision. And I think the true mark of genius in the world of art goes beyond one's own creations. It really includes the creations that you inspire and instill and support in others. Now, I'm really going to overuse this metaphor, I'm afraid, but in addition to his own art colony, he has been able to build bridges and to bring together people in collaborations around the country, literally around the world. And these are collaborations, these are bridges that he has built that will endure forever, whether it's the latest edition of an iconic textbook or the next huge, big, multi-center national study advancing our understanding of not only how to treat but also how to prevent disease. David has had this remarkable capacity of bringing people together with shared enthusiasm and shared vision so that his works of art become their works of art in a way that is remarkably synergistic. I mean, I was reflecting this morning as I saw the remarkable list of people who have traveled to come here today. In terms of his capacity to bring people together, any of you who have an appreciation of ACC basketball will understand how impressed I am that we have people here from Duke, NC State, and Wake Forest, all invited by a former Tar Heel. I will say that it's a good thing this is not taking place during March Madness. That would have been asking too much even of Dave. So on behalf of all the remarkable art fans whose lives have been touched by all of Dave's creations, I want to first and foremost thank Dave. I also have to say that, great artists back in the, if you'll pardon the expression, golden age of art, really had wonderful patrons. What's even more remarkable is that your patron has been a bunch of deans, and they are notoriously skimpy. So for all that you have done with the available resources, not only here but around the country, and for all the contributions you've made to human health and to our valiant battles against human disease, Thank you so much, and thank all of you for coming together for what I'm sure will be a wonderful occasion. Thanks.
I would like to introduce Marven Zelen, who probably doesn't need much of an introduction, but currently he holds the Lemuel Shattuck Research Professor of Statistical Science in the Department of Biostatistics at Harvard School of Public Health. And he was a chair of the department from 1981 through 1990. But probably most of you do not know that Marven had an earlier career on this very campus between 1961 through 1963, when he was visiting professor in the Mathematical Research Center at the university. And I'm very happy that Marvin's here today.
Thank you.
Yeah.
Can I sit?
Sure. Yeah.
You can turn the microphones on?
Yep.
And how do you...
I'll take care of that.
If you don't mind, I would like to sit. A little while ago, I got a herniated disc, so it's difficult to stand. Generally, I start with the first slide rather than the last slide. Well, I have been asked to discuss Dave's career, and how does one go about it when someone's CV is over 30 pages long? Let me see how I can manipulate this.
Marvin will control this screen.
Okay. Well, Dave can be described by being a leader, a scholar, a teacher, mentor, administrator, a visionary. I probably have left off a half a dozen other descriptive terms. He possesses great judgment and is in constant demand to serve as a program advisor for academic programs, as well as serving on national committees. He has been very influential in strengthening biostatistical programs and helping create national policy with regard to biostatistical support and influence in the U.S. He has the ear of the NIH director, as well as the director of many NIH institutes. His influence on national programs is legendary. The University of Wisconsin should be very proud of having him on its faculty. I met his mother yesterday. She's very proud also. I don't know if she's in the audience, but we should all thank her. Missing a slide. Can you? Okay. His education is in this slide. He graduated with a concentration in mathematics from the Gustavus Adolphus College in Minnesota, went on to get a master's and PhD at the University of Minnesota in biostatistics. Next slide. His career path has been mainly in two institutions, one at the NIH and the other at the University of Wisconsin. He began his career at the NIH in 1970 as a commissioned officer in the Public Health Service. I don't know if he ever got a uniform, but they were entitled to wear a uniform. After he finished his 2 years, he took a position with the National Heart, Lung, and Blood Institute in the Mathematics and Applied Statistics branch, and eventually he became chief of that branch in 1979. He came to the University of Wisconsin in 1982 as professor of statistics and biostatistics, and he was recruited by Paul Carbone and was made the associate director of the UW Clinical Cancer Center. Paul Carbone was the head of the cancer center. He became the founding chair of the Department of Biostatistics and Medical Informatics, and as we heard earlier, it's one of the premier departments in the world in biostatistics. Many of its graduates have gone on to very distinguished careers. In 1991, he was made the professor of biostatistics and medical informatics in the School of Medicine and Public Health, and then gradually progressed through the UW Medical School and was associate director of the Comprehensive Cancer Center and as the assistant director for clinical and traditional and translational research. A year ago, he was made the Max Halpern Professor of Biostatistics. And this was an award given by WARF, the Wisconsin Alumni Research Foundation, who recognized Dave's accomplishments. And I'm quoting what they described the award to be. It's an award intended to honor those faculty who have made major contributions to the advancement of knowledge, primarily through their research endeavors, but also as a result of their teaching and service activities. And Dave chose to name the professorship after his mentor, Max Halpern, at the NIH. And I will return to this later on in my talk. Now, this is interesting about the negotiations on how to recruit Dave. Paul Carbone, who was head of the UW Cancer Center, was a very good friend of mine. He wanted to recruit Dave for the center, as Paul was very enthusiastic about the contributions that biostatistics could make in the cancer center, but he also wanted to have someone who would also extend biostatistics to the entire medical school. He consulted with me on how to recruit Dave. At the same time, Dave consulted me on the negotiations. So here's how the negotiations went. I was in the middle, advising Paul. I was advising Dave, and we went around this way in order to recruit Dave. Towards the end of those negotiations, I put in a cautionary note to Dave about future promotions. I said, if you're going to do all the things that Paul Carbone wants you to do, you'll have very little time for independent research. And you might never get promoted in the Department of Statistics, because the Department of Statistics was the only department at UW where Dave would fit in. Surgery didn't look right. Internal medicine didn't look right. So Dave would be a member of the Department of Statistics. And the offer was as associate professor. So Dave and I had a very extended discussion. And I said, well, ask the department to outline what it would take to be promoted to professor. And Dave did that. And much to our surprise, they didn't reply, but they offered him a full professorship. So I'd like to take this moment to commend the Department of Statistics for having their insight, because, of course, Dave has been a marvelous faculty member, both in the medical school and at the University of Wisconsin. Now, Dave's influence, as I indicated, goes far beyond UW. As I indicated, his service on committees is legendary. And I have to mention a few of them. He was on the board of the scientific counselors of the National Cancer Institute. He's on the advisory committee of the director of the NIH. He has been very important in characterizing the data monitoring for clinical trials, and he has served on data monitoring boards for more than 100 clinical trials. He has other assignments. He has served on many committees at the FDA, committees of the National Eye Institute, the National Institute of Arthritis and Diabetes, Heart Association, Institute of Medicine, the American Statistical Association, Biometric Society, and so forth. I ran out of space on the slides. There are many others I've neglected. He's served on many, many advisory boards. He has been on Case Western Reserve, Dana-Farber, Duke, Northwestern, Rockefeller, St. Jude's, University of Texas, Virginia Commonwealth. He's in constant demand because his judgment is absolutely outstanding. And I've worked with him on some of these, and whenever Dave proposes anything, it always gets accepted. I can't say the same for myself. He has, despite all these service activities and leadership, he has a spectacular publication record. He's published 4 books. And I'd like to point out that the book with Furberg, Frieddman, and himself, which is entitled Fundamentals of Clinical Trials, is now in its 4th edition. And whenever I go visit universities and ask what they do about courses in clinical trials, invariably this book is the text for almost every course in the United States on clinical trials. He has over 200 peer-reviewed publications, and surprisingly, 25% are in statistical methods publications. I didn't think he would have the time to do statistical methods. You know, to do statistical methods papers, you can't do overnight. It takes a long time till you not only understand what you're doing and proposing new things, but arguing with all the referees. And the rest of his papers are in collaborative publications. Some of the diseases that he's contributed to are cancer, cardiovascular disease, ophthalmology, diabetic retinopathy, pulmonary embolism. And these publications appeared in the leading medical journals of our times: New England Journal of Medicine, Lancet, Annals of Internal Medicine, Circulation. So he's had huge influence with regard to the results of his work affecting other institutions, many patients, and certainly biostatisticians. I'd like to point out one paper which has had enormous impact on clinical trials. The paper with Gordon Lands and Dave, which appeared in 1983, was actually a revolutionary paper. And Gordon is here, and I think that we all should thank him as well as Dave for this publication, because it introduced and developed generalized alpha functions and enabled a great deal of flexibility on how to run clinical trials and spend the type 1 era. It has over 1,000 citations, and in biostatistics methods papers, if you get about 20, you're on the average. So this has had enormous influence. He has received, of course, many honors, as he deserved. But I'd like to point out that in 1976, he had an honor from the Junior Chamber of Commerce, who recognized Dave as an outstanding young man of America. I don't know of any statisticians who have that award, and somehow it left out women. He served as the president of the Eastern North American region of the Biometric Society. He's been the president of Society of Clinical Trials, and he's an honorary fellow of many scientific organizations. And he's received other awards from UW, from Harvard. He received the Alumni Award from his undergraduate institution. He received awards from the NIH. Next slide, please. Now, I'd like to turn to Max Halpern. Max Halpern was Dave's mentor at the NIH. And receiving the award from Worf, Dave had the privilege of choosing the title of the professorship. And he named it after Max Halpern. And many of us in this room remember Max with great affection. Shortly after his death, the journal Statistics in Medicine devoted an issue in memory of Max. Many of us contributed tributes in this publication. And in closing, I wish to cite Dave's tribute about Max, which was published 36 years ago. Dave wrote, "When I finished my PhD in 1970, Max went out of his way to help me find a position in the computer division of the NIH, even though we had never met. 2 years later, I had the privilege of joining Max at the Biometrics Research Branch of the National Heart, Lung, and Blood Institute. Initially, I was intimidated by this accomplished statistician with silver hair on a short, stocky frame. However, I soon learned that while Max could be very demanding and intense, he also was genuinely concerned about the professional and personal welfare of the young staff he had recently recruited. We affectionately referred to Max as the bear, and we, in hindsight, were his cubs. During the next 5 years, I had lunch with him almost every day we were in the office together. After a routine interrogation as to what I was eating, we often shared a few stories, but usually ended up discussing statistics. No question was too elementary, and I soon learned to be completely open. Max would delight in intensely debating a statistical issue all morning, breaking for a friendly lunch together, and then returning to the argument afterwards. He valued hard work, honesty, and fair play with little tolerance for pretentiousness. Eventually, I succeeded him as branch chief, and he always gave me his counsel without second-guessing my own decisions. It was truly a privilege and a pleasure to be associated with Max for almost 18 years. I shall always be indebted for the many ways he contributed to my career. One of my goals is to pass his gifts to me on to the next generation of biostatisticians. I miss him. So, wherever Max is, if he could look down, he would be immensely proud of Dave, as we all are, and simply say, "Well done, Dave." Thank you.
So we'll start a first scientific session chaired by Marian Fisher. And I would like to suggest the speakers of the first session to come sit in the front row. Let's Let's see.
There's 4 of them and 3 chairs.
Right.
So if you bring up Janet's. Thank you very much. I think we had an absolutely wonderful introduction from Dr. Zelen about all the background. And so I'm going to save time and just introduce all of the speakers at once and then have them move from presentation to presentation. As you heard, it's the Max Halpern Professorship. Dave was the branch chief. He was succeeded by our first speaker, Janet Wittes, who was succeeded by Nancy Geller, who's the 4th speaker in this session. In addition, as colleagues at the Heart Institute, he worked closely with 2 physicians, and they're listed in your program, Lawrence Frieddman as PhD, but he's an MD, and Curt Furberg, who is both an MD and PhD. So I'd just like to make that announcement. So now I turn the program over to this session.
Thank you, Marion. Well, I'm honored to be here, honored and rather moved, actually, at the passage of time and at the wonderful presentation that Marv gave about Dave. What I'm going to do is talk about, so what you all know now, and probably most of you knew before, Dave came to the branch, which was then called, and we'll go to the Mathematics and Applied Statistics branch, of the then National Heart, Lung, and Blood Institute in 1973. And what I would like to do is to go back and give you some sort of a history of what that branch was and what its contributions were, to give you a flavor for, I suppose I'm making up the history of what Dave must have felt as he entered that branch. The Institute was variously the NHI, the National Heart Institute, the NHLI, the National Heart and Lung Institute, and then finally the NHLBI, National Lung and Blood Institute. So we're going to think of it as the same institute, but it changed character over the times. And the branch was the biometrics research section, and then the biometrics research branch, and then the mathematical and applied statistics branch, and then back to the biostatistics branch. But we're going to call it BRB throughout. So let's think about the setting of this branch back in the late 1940s. Coronary heart disease was epidemic in men. And I'm stressing that this was men, because one of the criticisms later is, well, the NHLBI didn't pay attention to women. The epidemic in those days was in men. By 1950, about 1/3 of men were developing cardiovascular disease before the age of 60. It wasn't uncommon for a young man with 3 little children to go off to play a weekly volleyball game and come home dead of a massive heart attack. This was not something you didn't hear about when somebody my age was growing up. It was the fathers of kids my age. So important questions about heart disease were apparent. And then the methodology, the statistical methodology was young. In a different audience, one might say the medical methodology was young and so forth. But here we're focusing on the statistical methodology. Whoops. So I want to give you a flavor for the philosophy and legacy of the branch, which was there, I think, from its very beginning. The branch was always interested both in the trials themselves, in what the questions were being asked, and the methodology of biostatistics that would lead to answers, the trials to answer those questions. And as you could see from Marv's description of Dave, Dave's contributions were very strong, have been very strong, and will continue to be very strong in both the trials, the medical aspects of the trials, and the statistical methodology attached to them. The branch always felt a responsibility to the Institute as a whole. And that's a really important quality of that branch, that it was never fractionated. It always stayed as a unit, serving, and if Mary Folks were here, she would say, don't use the word serve, participating in, collaborating with the Institute as a whole, not wanting to be this person for heart, this person for lung, and so forth. That it was a branch of statistics that stayed cohesive. It felt itself that it had to be intellectually independent. It had to maintain a certain skepticism about what the docs were saying. It had to be rigorously, methodologically correct, and very engaged in what the medical questions were. Whenever its independence was threatened, and that happened at least twice, it moved. It would go to somebody higher up and say, we can't live in this environment. We need somebody else to protect us. And that's really the history of the change in name. That when it moved to be protected, and there was always somebody higher up at the Institute, at the NHLBI, who understood and valued the contributions of statistics and the importance of the branch to be able to say, no, I don't agree with this hypothesis, or no, I don't agree with this design, or no, I don't agree with this analysis. And that it had to be able to do that in a very independent way. The other thing about that branch is that it really served as a training. I mean, I don't know that the NHLBI would have liked this up front, but in fact, it has served as a training branch. People have been there, have made tremendous contributions, and moved on. Other institutions, for example, other institutes at the NIH, for example, the NEI, the National Eye Institute, that was really, I mean, in my view, the statistics group was an offshoot of the NHLBI's group, the BRB, that the way it formed itself, the way, again, it said, we are going to be the group for the Institute as a whole. That was an NHLBI model. Moved to universities, this being one, moved to industry, so people moved on. But I think it is true, and I'm looking around at previous members of the branch, that there's been a cadre of a closeness of people in that branch, even when we weren't there at the same time. There's been a sense of unity of the branch. So here's some history. First, I think, I'll tell you first the history of how I got the history. So I went to various places in the Institute to get a history. I wanted to say, can you give me a list of everybody who's been in the branch and all the branch chiefs? And the answer was, no, we don't have that. And then in Building 1, they said, well, if you want it, what you could do, we'll give you all the phone books from the beginning of time. So this is a history. I think it's right. There may be something wrong in the beginning. The first chief was Felix Moore, who was the head of the biometric section at the National Heart Institute, I think from 1948. It was certainly from before 1949. I don't know how much before. And I don't know when. I think until 1963. Jerry Cornfield had joined in 1960, and he became the chief of the biometrics research branch in 1963, and he was there for 5 years. Max joined the branch in about 2 years after Jerry did, and then became the branch chief after Jerry left. Jerry then went to founded the Biostatistics Center at GW, and then Max went there, and several of us have been there too. So there's been a lot of following each other. So the first was the BD, the before Dave era. Those were those three. Then the Dave era, and then the after Dave. And Nancy and I are the after Dave. So a little bit about Felix Moore, whom did anybody know Felix here? Did you?
I didn't hear you.
Did you know Felix?
I knew about him, and we exchanged nods.
So I think he's sort of, you did.
Because he was at the University of Michigan when I first met him.
I see. Okay. Because once you did two more. Is that right? Okay. Okay. Because once we get to Jerry, a lot of us knew him, but Felix was before that. I mean, again, you can see the generational things. So what happened? How did Felix Moore get to the NHLBI? Oh, sorry, the NHI. Harold Dorn, who was at the NCI, the National Cancer Institute, recommended him to the director of the NHI as a very good young statistician. And he was called up and he said, in all honesty, I've got to tell you, I don't know a heart from a Valentine. And the answer was, yeah, but you're a good statistician. You'll learn about hearts. We'll teach you about cardiology. So what did he do? What were his contributions, and how did they relate to the eventual growth of the institute, of the branch? So he was asked, what is a sample? Supposing you're doing an epidemiologic study, and you want a reasonable likelihood of establishing the relationship between given characteristics and the risk of death from heart attack in a 20-year period. Notice the complexity of this question. All right, this is in the late 40s, already seeing that you have to think of this as several decades, not just a little study, that you want to establish a hypothesis up front, and you want to ask a really important question. That question was asked of Felix Moore, and he came up with 5,209. I love that 9. Men and women, age 30 to 60. And so he was part of the birth of the Framingham Heart Study. The only National Heart Institute trial before 1960, I think, and if you guys know, but if you can correct me, do so, was a trial of the treatment of rheumatic fever and the prevention of rheumatic heart disease. Moore served as a consultant to that trial. He hired Jerry Cornfield in 1960, and Jerry became chief in 1963. Jerry, as many of you know, was very interested in the methodology of trials. But I want you to think back to 1960. There was no group sequential analysis. There was sequential analysis because of Walden Wolfowitz. And remember, Wolfowitz's son is Paul Wolfowitz. Walden Wolfowitz in World War II. There was no log rank test, no Cox model. So we're talking about going to be asking very important medical questions about cardiology without what we now think is, everybody knows how to do this. Jerry had a keen sense of recognition of multiplicity. He recognized that if you look again and again at data, there's going to be a problem of multiplicity. And he also recognized that you really want to know about subgroups, but there's all kinds of problems with multiplicity in subgroups. So I want to give one example of a trial in those days, the Coronary Drug Project, which a lot of you were involved in. It started in 1966, went from 1966 to 74, 8,341 men with previous MI. Again, the epidemic was in men. Primary outcome was all-cause mortality. And they did 5 lipid-modifying agents versus placebo. So this is a 6-arm trial with the placebo group. 2 of the arms were estrogen, and you can see the others there on the slide. What was remarkable is this trial was large, it was long, it was randomized, double-blind, placebo-controlled, and really started a long time ago. Whoops, sorry, went backwards. results, the high and low dose estrogens were stopped, first the high dose and then the low dose estrogen stopped early for adverse effects. The dextrothyroxine stopped a little bit later for early effects. Clofibrate didn't show benefit, and niacin showed a reduction in cardiovascular events, the mean follow-up time of a little more than 6 years, and all-cause mortality when they kept on following, 9 years after the treatment was over. So what were the lessons taken out of this really from for other trials? First of all, trials need to have a structure. Whoop! And slides should be in the right order. Okay, so lessons. It's important to ask important questions. The Coronary Drug Project asked a really important question. How do you prevent death and serious cardiovascular events? And it had the guts to ask it with several different interventions. Use rigorous methodology. And it developed a structure it was one of the early trials that developed a real structure for a large trial. It had a steering committee, a policy committee, which we would now call a DSMB, and all kinds of other lab committees, all kinds of committees, but a very formal structure. It taught that estrogen wasn't beneficial to men. Took another 30 years to learn that giving women, postmenopausal women, estrogen did not prevent a heart attack for them either. It taught in a very important way and to beware of analysis by adherence. And there's a wonderful paper, if the students haven't read it, by Paul Kanner that talks about that. And Jerry dealt with monitoring. How do you deal with monitoring? How do you deal with subgroups? And he developed a Bayesian methodology for that. He was very much an empiricist, as the branch has been philosophically. He always would say, show me the data. If you said something to him and you made a statement, his answer would be, show me the data. Max was the... what? That's not right. Well, I think I have the date. The date was right in the other slide. Max was there from 69 to 77, but not the chief all that time. He was very involved in the design of the multiple risk factor intervention trial called Mr. Fit by many and Murfit by Jerry Stamler. It was designed in 1971. Almost 13,000 men. So again, NHLBI was not afraid of very large trials even back then. Conducted at 22 U.S. centers from 73 to 82. And what it did was to identify men at high risk for coronary disease on the basis of a logistic regression selecting participants. So think of, here's the Framingham study, ask the question, what will happen, what are predictors of 20-year of events over 20 years? That starts in 49. 20 years later, there's now equations predicting risk. Max and the group, the NHLBI, use those logistic equations to choose people at high risk, and then modified, and the idea was to modify those risk factors, smoking diet, changing diet to lower serum cholesterol and blood pressure. There was the special intervention was this multiple risk factor intervention, and people were followed 6 to 8 years. Again, notice the themes. Use epidemiologic data that you have collected prospectively to define a population. Ask a very important question that has tremendous relevance to a population at large. Don't be afraid of large sample sizes. Don't be afraid of long follow-up. Do the right study. Max was interested in curtailing. Dave Alling had shown that you could stop a trial early if you had enough data to show that no matter what happened afterwards, the result that would not whether you were significant or not would not change. Max and several people in this audience also dealt with stochastic curtailing. How could you not be certain of that, but be sufficiently certain to make decisions about early stopping of trials? The beta blocker, the heart attack, not attach, trial, which was conducted from 77 to 81. So designed while Max was there, but Max had left just as it started, was stopped early for conditional power, and Gordon and Larry can probably, and Curt can probably talk more about that, but it was based on these thoughts that Max had had. It's funny, I was going to quote the words that Dave used about Max, decided not to. Very glad that Marven did. What Jim Ware said in that very same issue that Marven described, Max established a wonderful atmosphere at the branch. Looking back, we were blessed to have the time to debate many of the issues we found challenging. And Max was very much an empiricist. What I said in that is I love to watch him listen to a medical case history. He had the tolerance of an atheist hearing the report of a miracle. So, Dave, I will not talk. I'll just talk a very tiny bit about Dave, just as to move into the future. Dave, as you all know, and as Marven talked about, he and Gordon introduced alpha spending. Dave was very interested in data monitoring. The Darcy fraud case is a wonderful case to look at if you're which was Kent Bailey and Dave. And one of the things that Dave did was to become active in trials in lung and blood as well as in heart. So, to summarize the kind of methodology that the biometrics research branch was interested in, coordinating centers and administrative structure, monitoring, Bayesian monitoring a la Jerry, stochastic curtailing a la Max, sequential a la Dave and Gordon, subgroups, noncompliance, and both the design and analysis that noncompliance, the effects that noncompliance has both on the way you design a trial and the way you analyze it, and longitudinal models. In summary, the BRB worked very closely with the rest of the Institute and the investigators. The divisions recognized the importance of keeping the group intact. There was, the branch was, do I have one? Yeah, okay. Enough appropriate data, not just lots of data, enough appropriate data. It remained healthily skeptical of epidemiologic data and small trials in making inferences about treatment effect. It saw epi and biostat as synergistic, epi studies as templates for hypotheses, as in this relationship, the example that I gave, the relationship of Framingham to CDP. It had no, as a branch, it had no confusion, either intellectual or emotional, of association and causation. And the reason I say that is often people will say, well, yeah, association isn't the same as causation, but really when you see these two, you know. And it is this branch, with these wonderful leaders before, that Dave so ably led when he joined and became a leader. Thank you.
Let me thank everyone here for a wonderful, wonderful session, and I enjoy greatly being here to honor Dave. Let me add before I start here, let me add one or two things to Janet's talk. She mentioned the coronary drug project. In fact, when the low-dose estrogen was stopped on that, there was a sort of conditional power used in that. Earlier, they had stopped it when they stopped the arms when there could be absolutely no benefit whatsoever and, in fact, harm. But they started thinking in terms of conditional power with the low-dose estrogen arm. So it evolved, but it was quite a learning experience to work with Max and his group then. All these acronyms: Anturane reinfarction trial, aspirin myocardial infarction study. Janet already mentioned the beta blocker heart attack trial. Course intention to treat, National Heart and Lung Blood Institute, David L. DeMets. And I'll try to go through some of those. First, some background. There had been considerable laboratory and epidemiologic data that suggested that platelet active agents, such as aspirin, dipyridamole, or Persantin, sulfentrazone, Anturane, might be helpful in heart disease and stroke. During the 1970s, there were a number of clinical trials being done. Coronary Drug Project aspirin study. Two of the arms that were stopped early, the high-dose estrogen and dextrothyroxine, they re-randomized the patients in those two arms to aspirin or placebo in order to look at the aspirin issue. The Persantin aspirin reinfarction study, which was done at Maryland, Chris Klimt's group. The aspirin myocardial infarction study, which the NHLBI was doing. Anturane reinfarction trial, which was being done by a pharmaceutical company. Anyone know what AITIA is? More, you should know. It's the aspirin in transient ischemic attacks. Bill Field, Bob Hardy, Ralph Frankowski. These were going on quietly. Everyone was happy. In 1978, though, there was a publication in the New England Journal. It was a preliminary report. The study was still going on. It hadn't ended, but there was a preliminary report from the Anturane reinfarction trial, along with a very favorable editorial by the editor, Relman. Well, the Institute was saying, we have this aspirin study going on. What do? We also have the beta blocker heart attack trial going on in similar patients. Do we now have to put everyone on sulfentrazone? So I'll get into that, but let me, before I go through all that, let me summarize some of the dates there. This is not 2/28, it's 2/9/78. It was a publication of the preliminary Anturane reinfarction trial results. Later that year, the NHLBI convened a panel to discuss what to do, and I'll talk about that. The final Anturane results, I put final in quotes here, published 2 years later. The FDA denied an NDA for sulfentrazone, and I'll get into that. There was publication of an FDA critique of that study. There was also an Italian Anturane study that was going on. It was published in 1982. And there were reanalyses of the Anturane reinfarction trial in 1982, and I'll get into that a little bit. just want to, before I get into the other details of the data, show what the protocol said. The objective of the Anturane reinfarction trial protocol was to compare the effects of Anturane versus placebo on the rates of cardiac mortality associated with recurrent myocardial infarction in patients with a recent 25 to 35 days acute infarction. So they had survived acute infarction and were 25 to 35 days post-infarction. It was sponsored by Ciba-Geigy. The protocol also said that all the patients who have satisfied the protocol criteria, determined not necessarily prior to entry, have been subject to statistical analyses for efficacy. For the demarcation of time and study, a simple 7-day rule was provided by the medical personnel associated with this project. More specifically, time and study was measured from the 7th day after admission. Furthermore, a death was considered as analyzable if the patient was on treatment for at least 7 days and off treatment for no more than 7 days at the time of occurrence of death. These are the results from the 1978 publication. Little over 800 patients were entered into each group, sulfamperazone, Anturane, or placebo. After the fact, it was decided that only 733 and 742 of those patients were really eligible. Among the eligible patients who had analyzable data using the 7-day rule that I went through, there were 25 deaths in the sulfamperazone group and 44 in placebo, and as you can see, big reductions in cardiac death and sudden death. And there was a modest reduction in hospitalized myocardial infarction. These were the data that were published in the 1978 article. The study was not over, but they felt that these data were so persuasive, so important, that they had to publish them. Well, as I said, when NHLBI saw this, it said, what do we do with our aspirin study and our beta blocker heart attack trial? So it convened a panel. Well, first of all, the results from that, or the summary of the results from that article, sulfamperazone appears to be effective in reducing cardiac deaths during the first year after myocardial infarction. There weren't many patients who had been followed for more than 1 year at that time. So NHLBI contacted the sponsor, Ciba-Geigy, which provided it with the protocol of the study, which I cited, and data which went into the 1978 publication. And Dave was the statistician who was assigned to reanalyze those data for this review. And the review panel met in September. Members of the panel were Gene Brownwald, chaired it, Henry Blackburn, Bill Brown, Ed Jensen, Max Halpern was part of it, Jim Leonard. Other attendees, Ciba-Geigy had some employees, Sid Kane, Ed Margulies, Irene Chow. There were representatives. Saul Sherry was the head of the policy board overseeing that study. John Tukey was their statistical consultant. And the FDA had Bob Temple and Gordon Pledger, and there were several of us from the NHLBI. The discussion was contentious, to say the least. There was no consensus on the merits of excluding patients on the basis of subsequently determined ineligibility or the 7-day rule. Obviously, some of the people were very much against that policy. Others were very much in favor of that policy. Dave's reanalysis did show that if you look at those who were post hoc excluded, somehow the mortality was 3 to 7 the other way. In any event, the committee recommended no change in the protocol of either the aspirin myocardial infarction study or the beta blocker heart attack trial. As an aside, I don't know if Dave remembers, but John Tukey wanted to assess his statistical knowledge, and he asked you a question. Do you remember what that question was? Yeah. Dave passed, by the way. Now, it had to do with, can you have more analyses than the number of people in the study? 2 years later, the final results of this trial were published. Let me see if, yeah, here. And it was still favorable for sulfampirazone. The 2-year data showed all deaths 44 to 62, cardiac deaths 43 to 62, sudden death 22 to 37, and in particular the early mortality, that is the first 6 months after therapy, months 1 through 7, in other words, since they were enrolled approximately 1 month after the MI. There was even greater benefit, both cardiac death and sudden death. And the paper said the benefit of sulfampirazone was attributable entirely to a reduction in sudden death during the 2nd through 7th months after infarction, when there were 35 cardiac deaths in the placebo group. Of these deaths, 24 in the placebo group and 6 in the sulfampirazone group were sudden cardiac death. A sulfampirazone-induced 74% reduction in the calculated mortality rate. On the basis of these data, the company submitted an NDA to the Food and Drug Administration for licensing of sulfampirazone for this purpose. It had already been approved for other purposes. The FDA denied that NDA request. And what it said in the material it sent, the definitions used to assign causes of death were inherently imprecise and inadequately specified in the protocol. Favorable results depend heavily on exclusion from analysis of certain patients who completed the study. Later that year, Bob Temple and Gordon Pledger published an article in the New England Journal where they went through their analyses in somewhat detail, and this just breaks down the death by various categories, those who were ineligible, those who were eligible but hadn't been followed for more than 7 days, and those kinds of things. But the point is that the eligible and analyzable, which made of the cardiac deaths, which made up the bulk of the publication, 43 to 62, wasn't balanced by the rest of them, but was certainly attenuated by the other deaths in the other variety of the other categories. And this just shows the non-cardiac deaths, so that the total cardiac and non-cardiac deaths, while still favorable for sulfampirazone, Anturane, was certainly nowhere near as impressive. And what they said was the cause of death classification and all conclusions based on it are unreliable. The favorable effect of sulfampirazone on overall mortality, especially during the first 6 months, depends heavily on after-the-fact exclusion of certain deaths from analysis. In the published reports of the trial, it is difficult to tell how many deaths there were altogether, which deaths were excluded from analysis, and the exact reasons for such exclusions. I didn't go into it, but that's something that a number of us were very concerned about. The publications were far from clear. They were not as transparent as we would demand today. As a result of that FDA review, there were 2 reanalyses of the data First, the policy committee chaired by Saul Sherry, and second, an independent committee chaired by Bert Pitt, looked at all of the deaths and came up with their own conclusions as to what the deaths were. This is a little complex, but these are only analyzable deaths, first of all. It's not all of them. Only those that were thought to be, quote, analyzable. In other words, hadn't been followed for more than 7 days off drug and that kind of thing. For sudden deaths, sulfamperazone placebo, non-sudden, and all cardiac. 0 to 6 means 0 to 6 months follow-up, and 0 to 24 is up to 2 years follow-up. O is the original published report. R is the reanalysis of the policy committee, and P is Bert Pitt's committee. And the numbers themselves are less important than what there are differences. These are independent committees looking at the same data and coming to somewhat different conclusions, or not so much conclusions as numbers. And in, I guess, almost all, maybe all cases, there is an attenuation of the benefit when an independent reanalysis is done, whether it's at the 6-month or the 24-month period. So, lessons from this episode. Obviously, be careful about cause of death determination. It's not all that straightforward. Subgroup analyses, as has been mentioned before, are always contentious. After the fact exclusions, even if clearly ineligible, and I might mention here that some of these, quote, clearly ineligible, were on time of the MI. They were enrolled at 24 days instead of 25 days, or 36 days instead of 35 days. Things that you would think are obvious are not so obvious. And of course, withdrawals after the fact for a variety of reasons. Use intention to treat analysis. You don't get into these kinds of problems. And I guess my bottom line, and it reflects the results of the Italian study, which I didn't present, but were also favorable, mostly though for non-fatal myocardial infarction. There was a small reduction in mortality in the Italian study and a big reduction in non-fatal infarction, the opposite of what the American study showed. But based on that, plus what we now know about platelet active agents, sulfamperazone probably is useful. But carelessness and overenthusiasm ruined the artwork. Let me briefly touch on the beta blocker heart attack trial, which is Curt's baby. He started it. He was the one who developed the idea for it. That had, as I mentioned before, the same sorts of population as in the ART, which is why we were concerned about it. 3,837 post-MI patients, propranolol versus placebo, double-blind. The primary outcome, total mortality. We didn't want to get into the problem of was it due or not, was it a cardiac or sudden. And this just shows the Kaplan-Meier curve. You can see the big reduction in total mortality in the propranolol group. And this shows the O'Brien-Fleming boundary, and about 9 months before the end of the study, it was crossed, and the study stopped. The reason I'm bringing it up is Gordon and Dave were heavily involved in the analyses here. It used several kinds of analyses to look at whether or not the study should stop, and this is from a paper published in 1984 in Controlled Clinical Trials. Group sequential boundaries for repeated testing of accumulating data were used, unlike the Anturane study. They looked at likelihood of trend reversal. They looked at whether or not there would be additional precision from further follow-up. They looked at both internal and external consistency. So they did a number of things which today we would always do when we're thinking about stopping early or publishing early, but certainly wasn't done in the Anturane reinfarction trial. So BHAT lessons, intention to treat. It included ineligible patients, people who after the fact just, oh, gee, maybe we shouldn't have included them. Well, it included them. It was obviously an early, maybe even the first use of the group sequential boundaries. Emphasize caution in coming to conclusions. Can't let a few misclassifications or uncounted events change conclusions. You need enough data to be sure. And for a chronic condition, such as heart disease, you need a long-term study. Final words. Attention to treat. Attention to treat. Second bullet, don't jump too soon. Third bullet, don't overinterpret small numbers, subgroups, or subsets of outcomes. Don't play games with the data, even innocently. And finally, and this gets back to that NHLBI panel, fancy, high-powered statisticians and cardiologists don't necessarily know how to do clinical trials, though some of them can learn. Thank you.
Which one is forward?
This one.
That one forward. How did you need to go back?
This one. Use this one. This one will do.
Go back.
Yeah.
There we go. Forward is there.
Yep.
Dear Dave, colleagues and friends, I'm both pleased and honored to be here to recognize, David, your enormous achievements. I'm going to talk about a topic that may not be very popular, is drug safety, but I think it's important. I'm going to rely heavily on our book, Fundamentals of Clinical Trials, use a number of examples, and so it's a little bit of a promotional presentation. So, although in the book we are saying clinical trials is the most definitive method of determining whether an intervention has the postulated effect, we recognize that the assessment of efficacy and safety is asymmetric. And we also recognize there are 4, I added one, potential limitations in relying on clinical trials for safety evaluation. So what I'm going to discuss are the following limitations: the selectiveness of trial participants, limitations in statistical power, detection of late serious adverse events, the detection of unexpected events, and can't resist commenting on commercial biases. So, we are stating in the book regarding selectiveness that, in general, trial participants are healthier than non-participants with the same disease. Trials often exclude from participation those who are old, have other medical conditions, and or are taking other medications. And there are a lot of examples in the literature. Here are just a few. In a large number of trials of non-steroidal anti-inflammatory drugs, patients 65 years of age or older were excluded. They made up 2% of those studied. But in real life, they are the ones who really use the drug. It took quite a while to discover the harmful effects of the COX-2s, the increase in heart attacks. Part of that was because patients at high risk, coronary patients, were excluded. Clearly, we excluded pregnant women from evaluation of thalidomide. And a more recent example is the exclusion of subjects with psychiatric conditions or user of antipsychotic drugs in trials of smoking cessation treatments. These patients are the ones who develop problems at high risk of serious adverse events. I find this a very revealing report. It was a group of Finnish investigators who conducted a retrospective chart review. The typical eligibility criteria for clinical trials of patients with gastric ulcer were applied to 400 patients hospitalized with a diagnosis of gastric ulcer. Only 29% of the patients met the eligibility criteria, and almost all death and serious complications such as gastric bleeding, perforation, and stenosis during the first 5 to 7 years occurred among those who would have been ineligible. So much for representativeness of study populations, study patients. We need to be very careful when we extrapolate from trials to real life. Limitation in power is nothing new. This is a quote from David in the book, that due to limited power, clinical trials are unreliable for detection of rare serious adverse events. So if the true incidence is 1 in 1,000, you need 3,000 participants to detect a single case with 90% probability. And for a total of 6,500 participants, you'll detect 3 cases. And why is that relevant? Well, prior to approval of drugs, approval by the FDA, you typically have 1,000 to 5,000 patients in the pre-approval trials. So clearly we don't detect rare events. Examples, we have antidepressants and sudden death. We have rosiglitazone and heart attacks detected maybe 10 years after the drug was approved. More recently, we are discussing whether varenicline is involved with serious neuropsychiatric adverse effects like suicide and violence. The suicide and violence are not the typical adverse events we attribute to drugs. But we looked at that, and it turns out in the FDA labeling, 58 drugs have either a warning or precaution related to suicide. None of them was documented in the clinical trial. They're all based on individual reports. Violence, the same thing. It's nothing reported, maybe not even collected on the study form. But over 30 drugs cause a remarkable increase in either homicidal ideation or injuries. So we need to rely on more than clinical trials if we're going to really evaluate the rare events, because trials do not discover them the way they're conducted. A more recent example is tiotropium respimat Spiriva and mortality. This is an anticholinergic drug for long-term use in patients with chronic obstructive pulmonary disease. And it illustrates that there is a solution to the low power in individual trials. you combine them in meta-analyses. And that's what we did in this illustration, a meta-analysis of 5 trials of Respimat. I should say that the FDA rejected the drug in U.S., but the drug is approved in Europe and other countries in the world. And these are data that came up at an FDA hearing, showing that there were trends for harmful effect in many of the trials. So we did a meta-analysis, combined the data. If you combine both dosages, the 5 microgram and 10, the risk ratio is 1.52, p-value is 0.02. So a significant increase. And here you can see then for each dose, weak significance and a possible dose-dependent adverse effect. So I'm just making a plea for more meta-analyses of drug safety. We're going to learn more about the safety of drugs. Detection of late events, another issue we have to deal with. So when a new compound or device is introduced, sometimes we only have several hundred patients treated for 2 years or longer. Those are the regulatory requirements. You don't have to follow them longer. And this is obviously inadequate if you're going to use the drug for chronic purposes. So a long lag time to harm must be considered, particularly if we have some indication that the drug may be carcinogenic or have adverse metabolic effects. And we know that the lag time for carcinogens is much longer. Just think about smoking and lung cancer. It may take a decade to see an increase. The trials are too short. And the extreme example is DES and vaginal cancer, which didn't show up until the women taking the drug had daughters, and the daughters developed vaginal cancer. Right now we're discussing pioglitazone, a drug for diabetes and bladder cancer. And I think another striking example about late things is statins and diabetes. Statins were approved, the first one I think in the mid-90s. There was a meta-analysis published 15 years later, shown here, of 13 trials testing statins of any type versus placebo. You can see the point estimates for the trials varied quite a bit. Most of them were to the right of the line of unity. And then if you look at the bottom, the diamond shows that there was a statistically significant increase in risk of diabetes. But the increase is small. It's only 9%. But it still could be an important factor. Probably not offsetting the dramatic benefit of statins, but at least important to monitor this. Unexpected effects. Trials have a limited value for detect unexpected serious adverse events. Since data collection is typically decided prior to enrollment of the first trial participant. So what is unexpected is by definition not pre-specified and can't be included in the data collection forms. So the only way to collect it is to have maybe open-ended questions, but that's not really very useful. I think the one classical example is fen-phen and cardiac valve abnormalities. Another recent one, PPA and hemorrhagic stroke, had been on the markets for decades. It was reported around year 2000. cough, common side effect of ACE inhibitors, was not discovered until many, many years after the drug was approved. It's not included in the labeling. And now we're discussing alendronate or Fosamax and osteonecrosis of the jaw, not seen in trials. The fen-phen story is interesting. There was an observant, my term, echo technician in North Dakota who noted an unusual heart valve abnormality during an examination of an obese patient treated with fen-phen. She notified her cardiologist, who dismissed her observation. The cardiologist changed his mind when the technician made the same observation in the second obese person on fen-phen. The echo findings from a series of patients from North Dakota were written up, submitted to the New England Journal of Medicine. The report was rejected. So the investigators teamed up with a more reputable medical group, added some cases, resubmitted it to the New England Journal of Medicine, and lo and behold, there it was, featured article. And again, the discovery had nothing to do with clinical trials, just individual cases reported, case reports. So, publication bias, common both everywhere, in academia and in industry. And I think it's important, and we all at least trying to adhere to the principle that we prepare and submit trial results whether they are positive, neutral, or negative. And that, I think that should be an obligation. But that's not the case for a variety of reasons. If you look at medical journals, most of the articles reported are positive. But I should point out that if you look at sponsorship, industry-sponsored trials are 4 times more often positive compared to non-industry-sponsored trials. And you wonder what is behind that. There are also violations of the fundamentals that we cover in our book regarding the design, analysis, and the reporting. And I think Larry gave a wonderful example in the Anturane infarction study. We see the same thing today, violations of the sound principles. Some examples, there was a recent report from a congressional hearing where they looked at the SSRIs in adolescents. And there were 13 trials. 3 reported favorable results, 10 didn't. The former were published in high-profile journals. The latter remained unpublished. I think it's shameful, and it should not be accepted. Vickers did an interesting analysis about geographical distribution of this problem, reviewed the number of abstracts published between 66 and 95 and classified them based on treatment outcome. Of trials from the UK, 3/4 were positive for the new treatment. The corresponding percentages for China, the Soviet Union, Taiwan, and Japan was 99, 97, 95, and 89% respectively. No trials conducted in China or the Soviet Union reported that the study medication was ineffective. So you can see why there is a temptation to go to those trials if you want to evaluate your new drug. This is a wonderful example. I can't resist showing that again, relating outcome to sponsorship, a study by Harris. He and his colleagues reported some years ago about 42 trials comparing second-generation antipsychotics. 90% of the 33 industry-sponsored trials reported a favorable outcome favoring the sponsor's drug. And the most striking one was the report was 9 trials comparing the same 2 drugs. 9 trials, the same. What do you expect if you compare the same 2 drugs? Results should be fairly similar. Look at the top here. Olanzapine, risperidone. Eli Lilly supported 5 trials. They were all positive for Lilly's drug. Janssen did 4 trials. 3 supported its drug. 1 the comparator. So you wonder what was wrong with that single trial from Janssen that didn't show. Clearly, this is not a chance finding. Cannot be a chance finding. This is the way the trials were set up, conducted, analyzed, and reported. And this is, I think, is troubling. So the solution, well, except that we can't rely on individual trials for safety evaluation. Individual trials may be inconclusive, and the fallback is to do a meta-analysis. We need to accept observational studies for detection and documentation. And it's very interesting that the Institute of Medicine came to the same conclusion. And earlier this month, they said, depending on the frequency, magnitude, seriousness, and timing of a suspected adverse event, in many situations, observational studies may be preferred for post-marketing research to assess a drug's risks. And others have stated the same thing. Here is just an illustration how case reports can be useful. Classic paper by Venning, who looked at 18 well-recognized serious adverse events. And how were they detected? That was the purpose of his study. 13 were first published as case reports. 1 was a clinical trial. And I don't think the situation today is much different. So, but people are saying you can't rely on adverse effects. You can't get risks. You have no denominator. You have a serious underreporting. So we decided to look at that and looked at all FDA actions that led to labeling change in 2009. There were 182 such actions. Adverse drug events reports were the primary source of 76% of all new boxed warnings, the most serious adverse event. Most of it was based on individual events, not clinical trials. So we have to accept, even the FDA is relying on it for its regulatory actions. Trials made up just a small fraction. So in conclusion, trials are very, very useful, gold standard, not question for evaluating efficacy. For safety, it's good, but not as good. We need to use all the evidence we have. And we need to accept that observational studies, including case reports, are important complements for detection and documentation of drug safety effects. Thank you for your attention.
Stick in my pocket. Okay. Well, good morning. This is working? Yes? I, too, am very honored to be here. To join into this wonderful celebration. I represent the present National Heart, Lung, and Blood Institute, Office of Biostatistical Research, Office of Biostatistics Research, which is the successor to the groups known by various names over its history,
the change to this name was not because of adverse events. It was because branches were less prestigious at a certain point, and the biostatistics was considered better than a branch. A lot of things have changed since my predecessors speaking this morning at the NHLBI, and one of them is the logo, which I have in the bottom corner of my slide. This is to represent a heart in between a pair of lungs, all encircled by a drop of blood, and any resemblance to two cats kissing is purely coincidental. So the Office of Biostatistics Research has offices in a long hallway, and there was this big empty wall. And so we posted the photos of some of the branch chiefs, the previous branch chiefs. The sign says Biostatistics Research Branch, not Biometrics Research Branch. Now, when I arrived in 1990, that was the sign I found. So somewhere along the line, the branch changed names from Biometrics Research Branch to Biostatistics Research Branch. So I took this picture and happened to capture Max Halpern in the middle and Jerry Cornfield in the beginning. And Dave's picture is there. And I did not capture Janet's picture, which is on the wall next to Dave's. But that's because of the limitations of a BlackBerry camera. So Dave was the branch chief, as has been mentioned, between 1977 and 83. So what I'm going to speak about today is Dave's wisdom in data and safety monitoring boards, probably a contribution that even he doesn't realize he made. And secondly, I'm going to speak about Dave as an NIH nudge, and I'll explain that as I go on. And thirdly, and perhaps most importantly, I'll talk about Dave and the Summer Institute for Training in Biostatistics. So Dave was on the Data and Safety Monitoring Board of the Women's Health Initiative, which has been mentioned previously. And in that trial, postmenopausal women were randomized to hormone replacement therapy with estrogen plus progestin if they had an intact uterus, or placebo. And there were two trials, a second one for women without an intact uterus. The primary endpoint was coronary heart disease, and that's defined here. And the primary adverse event was invasive breast cancer. So the initial plan was to monitor these as well as certain secondary outcomes with Bonferroni correction, including stroke, pulmonary embolism, colorectal cancer, endometrial cancer, and hip fracture. Now, this was a trial in healthy women, and Dave said, we have to monitor total mortality. You can't do a trial without monitoring total mortality. And there was a discussion about this because these were healthy women and deaths were not expected. But in any case, death was included in the monitoring plan as one of the potential adverse events. And this quote, "You've got to monitor overall mortality," rang true to my ears. And many years later, in the design of ACCORD, which was Action to Control Cardiovascular Risk in Diabetes, everybody was in the glycemic control trial and either in a cholesterol-lowering trial or a blood pressure-lowering trial. Again, a very complex trial with complex monitoring. And I want to talk specifically about the glycemia control trial. The primary outcome was non-fatal MI, non-fatal stroke, death due to cardiovascular disease, and secondary outcomes included components of the primary outcome and microvascular outcomes. Notice there was no mention of overall mortality. But you never do a trial without monitoring total mortality. So late in the game, we added total mortality to the monitoring plan. And indeed, ACCORD was stopped on the basis of total mortality because of an excess in the intensive glycemic treatment group. So Dave had an influence on a trial that he had no connection with. And that's just one example of the kinds of contributions, some of the kinds of contributions that Dave has made. So I want to talk also about Dave as an NIH nudge. So for those of you who don't know, what is a nudge? From the free online dictionary, nudge means to push against gently, especially in order to gain attention or give a signal. And the slang meaning for nudge, it comes from the Yiddish word to pester. So Dave, even after he left NIH, visited Claude L'Enfant, who was the director for many, many years. But he was also Dave's old friend, because prior to being the director at NHLBI, he was the director of the lung division, and Dave worked with him on trials in the lung division. So they were old friends, and so Dave was coming to NHLBI, at NIH in general, and so he would visit Claude. And what he would do was to lobby for biostatistics, both for training and research, and for funding in these. And in fact, Dave published on biostatistics training in the American Statistician in 1994. That was his first paper in that area. And this is the abstract from that paper. Some of the co-authors may be here. So, in fact, the summary is that there were challenges in training the next generation, a growing demand, shrinking training support from NIH, and the need to reshape curriculums to satisfy new research needs. He also noted the need for non-technical skills, such as interaction and communication and leadership on the part of biostatisticians. And these challenges remain with us today, even though this paper was written in 1994. So several years later, there was in 2001, an NIH workshop on training of biostatistics. And it had several recommendations. One was to establish a general biostatistics training grant program. If you recall, the funding given by NIH is usually disease-oriented. The funding is given by institutes. Institutes are associated with diseases. But biostatistics transcends all fields. He also advocated improving the peer review system for biostatistics training grants. Often within an institute, there may be one biostatistician on the review panel. And also some program to stimulate undergraduate interest in biostatistics and bioinformatics, something like a summer workshop with graduate school as the goal of the enrollees. So a second workshop followed in 2003, which recommended a general medical sciences biostatistics training grant initiative. And this has come to be, and I just won't spend any more time on this because I want to speak about the training aspects. So this is a paper published in 2006 in Statistics in Medicine's 25th anniversary edition called Training of the Next Generation of Biostatisticians, a Call to Action in the U.S. And it summarized the roles of both workshops. And as a recommendation of the 2001 workshop, the Summer Institute for Training in Biostatistics, known as SIBS, was born. Dave is responsible for the idea, but not the cutesy name. So in January 2003, NHLBI released a request for applications for a Summer Institute for Training in Biostatistics. The goal was to increase interest in biostatistics among advanced undergraduate students majoring in math and other quantitative areas, and the goal was also to encourage students to go into the field of biostatistics. So the initiative asked to develop and conduct and evaluate a summer course in basic principles and methods of biostatistics employed in medical research, would be offered in the summers of 2004 to 6, and would be reviewed by a special emphasis panel, again echoing the recommendation of Dave's paper. Criteria were the training program, the quality of the training program, and the program leadership, and an evaluation and dissemination plan. The SIBS initiative was to offer one grant for these 3 years, it used the T15 mechanism, which is short-term training, and would enroll between 20 and 40 U.S. citizens and permanent residents for 5 to 6 weeks, with emphasis on data analysis and the essential role of biostatistics research in biomedical research, and talk about career opportunities. And one metric was the proportion of participants going to graduate school in statistics and biostatistics or into a related field. So the RFA stated that one program would be funded, but in fact 3 were funded. It came up in at October Council, the end of the September Council, the end of the fiscal year, and it was the gravy days. So in fact, and SIBs are cheap. So they decided that 3 would be funded, and those 3 programs were at the University of Wisconsin, North Carolina State, and Boston University. So the SIBS program was a coordinated program, and began with a meeting of the PIs at the NHLBI in the fall of 2003, had regular conference calls, coordinated dates and advertising and recruiting, and used a wide range of mechanisms to publicize the programs. So there's a mass mailing of over 1,000 departments of statistics, math, engineering, computer science, and biology. And there's also advertising via word of mouth, a Friends of SIBS email list, and flyers circulated at ENAR. And each SIBS has a website, and the NHLBI website is listed here, as is the Wisconsin website. You can reach all of the SIBS programs from the NHLBI website. This is what the poster looks like. Opportunity for undergraduate and beginning graduate students, if you like mathematics, statistics, or science, and would like to explore how to apply quantitative methods to investigate important health issues, then SIBS is ideal for you. And we have our little SIBS logo. Here's some data on the success of SIBS. It was overwhelmingly successful in the first 3 years and was renewed for 2007 through 2009. This table shows that in the 6 years, the 3 universities trained over 400 students, and of them, something like 60% went to graduate school, and a higher percent even were in a related field, which means working as data coordinators. I think medical school is also included, to be honest. So SIBS actually has always gotten rave reviews, both by the participants and the evaluators, and a competing renewal known as SIBS 2 for 2010 through 12 was awarded. So, in fact, the renewal stated that 7 programs would be awarded. In fact, 8 were awarded. And the awards went to the original 3 programs plus the other universities listed here. And it was co-sponsored by the National Center for Research Resources, which is now defunct, but they pay for 2 programs. And collaboration of the programs continues. These are some information from the website of the University of Wisconsin SIBS site. This is the class of 2011, the SIBS program. Notice everybody's smiling. And one of the courses I noticed was Tacos with Dave, discussing careers in biostatistics. Dr. DeMets personally hosts an event known as Tacos with Dave. Over a dinner of tacos and other delicious Mexican food, students have the opportunity to talk with Dr. DeMets and other faculty about career opportunities in biostatistics. This informal environment allows students the opportunity to freely interact with the faculty and ask questions about how best to further their education and careers. It doesn't say that Dave cooks. This is the SIBS alumni news, Dave's column in the winter of 2011. It says that he's no longer in charge of SIBS, but he's going to have more time for SIBS. He's still a participant. And currently, SIBS for 2013, I put 14, but that's not right, 13, 14, 15, is currently under review. It is co-sponsored by NCATS, the successor to NCRR, and they will sponsor 2 programs, NHLBI, the other 6. And I need to note that a T15 cannot continue forever, so some changes will have to be made. There's a new NHLBI director coming on board in August, and so Dave will have a new person to go and see. Dave or any of you here, and training in biostatistics does indeed need advocates. So here's what we learned from Dave. You should never do a clinical trial without monitoring total mortality. Dave's kept NIH's eyes on biostatistics, a discipline that it might otherwise easily forget. And funding for training in biostatistics is really important, and Dave has been a terrific advocate. And when Dave talks, everyone listens. Thank you.
Kidman has told me that we can take 5 to 10 minutes for questions, and there are 2 microphones for questions for any of this morning's sessions. Speakers, additional things? Rob.
I always have questions, and any of you could answer this, but my perception, and I think it's validated by the efforts of the CTSAs to understand the needs of academic medical centers, I don't think the gap in training of biostatisticians is narrowing. I think it's widening considerably. That is, if you ask academic research faculty what's the number one issue that they're troubled by, it's inadequate access to quantitative collaborators. So, I'm not one. You guys are in this club, which is mostly represented today. Nancy, maybe you could start. Beyond Dave going and personally jawboning Francis Collins and Gary Gibbons, what can be done to change this situation?
Actually, you can go.
I'm there all the time. I'd also like to hear from Dave.
No, I'm serious, because I think a clinician saying we need more training for biostatisticians will have another kind of impact. It's one thing for me to say it, or it's better for Dave to say it, because I'm there already. I have less influence in the sense of being the advocate for the field. But I think a clinician saying it will also be highly effective. I think we can't have enough publicity. I think going from 3 SIBS programs to 8 is bringing more people into the field, yes. But then you need an increase in training in graduate programs, which may not be running along at the same pace.
So one comment, I guess, is that I'm currently co-chairing a committee for Francis Collins on NIH informatics and related subjects. The report is to be delivered on June 15th and is being written as I sit here. But I'm trying to sneak in the appeal for training under the term quantitative science, even though informatics is the name of the game. But we're trying to establish the fact you just said, Rob, is that the gap is not, it's widening, not getting smaller. And 2, that we need a better peer review system, because what happens to training grants is they get tucked in with all the other biology-based training grants, and the reviews we get are nothing short of ridiculous. So we'll see if we get the attention of the director of NIH, but really, the director of NIH in this matter, in this particular case, has very little influence. It'd be more the director of NCATS, perhaps, where we can get some traction. So it's a problem. No institute denies the problem. No institute wants to take ownership of the problem, and so we just go round, round, round.
Following up on Curt's presentation, I salute you for bringing out the challenges and the importance of safety assessments. I guess I would say, though, is it more complicated than saying for efficacy we need randomized trials, for safety we need meta-analyses of observational studies? Isn't it really more the level of relative risk that we need to pick up? So most of the time in efficacy, we're looking at small relative risks. We need randomized trials. Although for antibiotics and pneumonia in the 1950s, when we were getting a threefold reduction in mortality, we could do that with an historical control. On the safety side, very often we are looking at big relative risks with intussusception in the rotavirus or with progressive multifocal leukoencephalopathy with Tysabri. We didn't need a randomized trial. Yet, for a COX-2 inhibitor like celecoxib, where we're worried about a 1/3 increase in cardiovascular death, stroke, MI, or for an immunosuppressive agent in OA-RA, where we could worry about malignancies that would be 10, 20, 30% more. The same thing with ESAs. How can you do that with a meta-analysis of observational studies? And isn't the reason that we haven't had very many safety assessments recognized by FDA is that we've had very few proper randomized trials for safety assessments that really matter, but aren't odds ratios of 5 that I can get from an observational study, but are odds ratios of 1.3 to 1.5 that need randomization. So I guess I'm advocating for randomization here, where it's needed.
I think ideally you would have randomized comparisons, but I'm saying we rarely have that for many of the drugs that are introduced. Either we don't ask the right questions or we discover things after the fact. And I think what I'm making a plea for is to use all available information, include the observational study. Don't throw them out like many people tend to do. We need to rely on them, and we may not get perfect answers, but at least enough to alert patients and their physicians. I didn't talk about meta-analysis of observational studies. I showed a lot of examples of meta-analyses of randomized trials, and they are very useful to discover even smaller adverse effects.
And I endorse your point that we need to use what we have. I guess I'm saying, however, we shouldn't be satisfied with what we get. We should be proactive to say when there are important health issues that require randomization and post-marketing safety studies, that we need to go after the advocacy that such studies be done so that we can properly understand benefit to risk in large-scale settings.
I couldn't agree with you more, but on the other hand, there's also a time factor. And the whole issue, for example, about Chantix and neuropsychiatric symptoms, the company was given 7 years to do a short-term study of 8,000 patients. It's absurd. It should be some time urgency also when we recommend studies.
Marv?
I think the morning discussion is very interesting from several points. I'd like to point out that there are inherent limitations in our clinical trials, as Curt pointed out. First of all, nearly all of the statistical methods we use for analyzing studies require a random sample of patients. There are no random sample of patients. And what that means is, though we would like to interpret the data to deal with what's the best treatment for a particular disease, the only real interpretation we can get is what was the best treatment for the people who entered the study. Any further inference requires an extrapolation which may or may not be true. And you can find all kinds of examples, as Curt pointed out, where you get wrong results. With regard to training, we have been a complete failure in trying to interest what I call indigenous American students to study biostatistics, despite the fact that there are many very important and good job opportunities. And if it wasn't for the students from Pacific Rim nations, our area would be very, very thinly populated. And we should do something in the training to be able to sponsor people who don't have green cards. Now, I come from a private institution where the training grants do not completely support the tuition. We have to somehow find funds to make up generally anywhere from a $2,000 to $6,000 shortfall for every student. And I think the pharmaceutical companies somehow should be persuaded to take much more of an interest in the training rather than rely completely on the NIH to support training.
I think another thing is how you interpret a clinical trial where you see no increase in adverse effects. Some people say the drug is safe. They fail to recognize that a lack of statistical significance is not the lack of an adverse effect. You can never show that there is no difference.
Right. Just back to Marvin's point, the NIH has the funny little policy that only support only goes to those who are American citizens or who hold a green card, so that SIBS and its effect on graduate training may change the face of biostatistics in the next few years. You don't see necessarily fewer students from the Pacific Rim, but that's because their parents are the ones who came here.
So we're going to close the questioning now, and I turn it back over to Curt and thank everyone.
Just a few comments on housekeeping issues. Those of you who need to use the restroom, go out, make a left turn, and make another left turn. Then immediately you'll find the restroom. And for those of you who need to have some private time to prepare your talk, there's a hospitality room on 1626 across the atrium. And that's all I have to say. Oh, except there's a group of students who's participating in this year's SIBS program. If you are the students, would you please sort of stand up?
They were former students.
Oh, or former students. Okay. So let's make a break for 20 minutes and come back and sharp at 11 o'clock.